sir has made very good attempts to bring in the knowledge from all parts of the country. And we are so fortunate that we'll be listening to yet another exemplary speaker, Dr. Khanna, Ranjana Khanna, who is known for her organizational skills, for her scientific contribution. And we are going to listen to very important topic today, that is the thrombocytopenia in pregnancy, which puts a shudder down everyone's spine, right from the anesthetist to the surgeon to the obstetricians to the hematologist, as to are we going to touch this patient and come out safely out of whatever we are dealing with. So this is the topic which we have for the evening, and I heartily welcome Dr. Vidya Thobi ma'am, our president, who is ever there for all the activities of Kcog and Kcog, Dr. Muralidhar sir, the Dean of Kcog, who has masterly crafted all the learning procedures for Kcog. And welcome to all the delegates who are here. Over to you, Vidya Thobi ma'am, to give you a welcome address.
Yeah, really, I must say that it is one of the wonderful initiative by our chairperson, Dr. Muralidhar Pai. It is a very focused speaker and who will be speaking on certain subjects. And today's topic is very interesting as well as academically very oriented. And the speaker, none other than my dear friend, Dr. Ranjana Khanna. I am associated with her since ages, I must say. I started with I was in one of the panel with her in abnormal uterine bleeding in Pune. From there, our friendship started, and I think she's one of the best organizer for various. I think every year she will do 1 or 2 conferences at Prayagraj. And I have been a part of her ISOPARB webinars, and those are also very focused webinars, and she always chooses right topics and the right speakers. So I will not talk anything about thrombocytopenia or anything or any topic she's speaking. I'm going to speak today. I'm going to listen to her, as well as I am very proud of Dr. Muralidhar Pai. Now he is in Sikkim and we are missing him here, but he always connect to us through this webinar. So thank you very much, and welcome all from Kcog as well as Kcog. I'm eager to listen to Dr. Ranjana Khanna. Over to Rajeshwari. Thank you very much.
Thank you so much for the address. In spite of your busy schedule, you could make it to come on the screen and address the gathering. Very kind of you. And I now request Muralidhar Pai sir, the chairman of Kcog, chairperson, to please introduce our guest speaker today, Dr. Ranjana Khanna.
Yeah, respected President Dr. Vidya Thobi ma'am and Secretary, Dynamic Secretary Dr. Rajeshwari Paldi. On behalf of Kcog, that is Karnataka College of Obstetrics and Gynecology, I think it's the first of its kind in the whole country. We started this in 2020 when I was asked to just chair a committee of medical education. I suggested that why don't we start a Karnataka college on the lines of ICOG. That time, Dr. M.G. Hiremat, Dr. Hema Devakar, they all appreciated the idea, and thus the college was born. And continuously, we have been having this Cpap program for more than 3 years now. Today's is actually 36th Cpap program. In between 1 or 2 months, we missed during the Kcog conferences. Today, it is my proud privilege to welcome heartily on behalf of Kcog and Kcog, Dr. Ranjana Khanna. I should say she is my mentor. She has been inviting me conference after conference. I agree with both Dr. Vidya and Rajeshwari Paldi that she's been conducting innumerable conferences. Madam must have lost count of how many conferences she has conducted. She has been the Vice President of Foxy in 2017, and she's the founder of ISOPARB Prayagraj 2021-23. At the same time, she was also ICOG Governing Council member, and she has been the president of Allahabad Obstetrics and Gynecology Society between 2013 and 16 for 3 long years. Organizing chairperson now, she's conducting a conference December 15 to 17, same time as Kcog conference. Unfortunately for me, I am missing both the conferences. I had invitation from my home society, that is KSOGA, to be a speaker, and I am the chairman of the KCOG. I should be there. Madam Ranjana Khanna also has invited me as a speaker, but I am missing both of them due to my family commitments. And Madam has several awards, and to just highlight some of the national awards she has won: Foxy Achiever Award in 2022, Foxy Dhira Award is 2022 again, and Foxy Dr. D.K. Tang Reproductive Health Promotion Trophy. And in 2015, Foxy Smriti Mailan Award, that is for the Save the Girl Child, AKOG 2013. She has been a faculty of various national and international conferences in obstetrics and gynecology. She has delivered the prestigious Dr. Prabha Malhotra Oration in 2023 in UPCOG Lucknow. She is the author of many articles and chapters in various books and journals, and she is the co-convener of Foxy GCPR in epilepsy in pregnancy. But today she is going to enlighten all of us on the very intriguing topic. As Dr. Rajeshri correctly said, the thrombocytopenia is a dreaded complication of pregnancy. It can be also a complication of other complications in pregnancy, like DIC due to abruption, and also in cases of severe preeclampsia. So today we are going to have a very comprehensive view about that. And to speak that, we have a very erudite speaker, Dr. Ranjana Khanna, ma'am. So I invite you to give your talk today. Over to you, ma'am.
Thank you so much, Dr. Pai, for the lovely introduction. Now it's all right?
Yes, 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 ma'am.
I'll have to remove one of this, no?
No, it's fine.
Okay. So, very good evening. I'm going to speak on a very, very interesting topic, which has gained actually so much importance, because nowadays, at least in our part of India, there are increasing cases of dengue. And in dengue, the most important thing that is happening is thrombocytopenia. So even the layman is talking about platelet counts. And there is a heavy rush of buying kiwi, and papaya leaf extracts are being sold in the market. So it is even all the patients who come to us, even if they are just feeling weak, the first thing they'll say is, Madam, हमने अपना platelet count कराया, but that was normal. So, and they expect that the first thing that you will get done is a CBC, which will tell you about the platelet count. So nowadays, it has assumed a very big proportion, humongous proportion actually in our part of the country. And at the same time, we are having viral infections also. So the platelet count is going down in that also, causing a lot of distress. But people are becoming more and more aware of this problem. And since many patients are pregnant, so it is hitting them also. So what is thrombocytopenia? Thrombocytopenia is a condition when the blood platelet count is less than 1.5 lakhs. And this is the second leading cause of blood disorders in pregnancy, second only to anemia. Complicates 7 to 10% of all pregnancies. There is normally a physiological decrease in platelet count in pregnancy due to hemodilution, increased consumption in the peripheral tissues, and increased aggregation because of higher levels of thromboxane A2. Physiological thrombocytopenia of pregnancy, however, is mild. It has no adverse effects either on the mother or on the fetus. Guidelines consider that vaginal delivery is safe when the platelet count is more than 30,000. For vaginal or cesarean, we consider 50,000 as a safe count. But if you have to give epidural anesthesia, then the safe platelet count is 75 to 80,000. Risk of epidural hematoma is there with lower platelet values. Spontaneous bleeding may occur with less than 20,000 platelets, and the risk of internal bleeding is markedly increased if the platelet count goes less than 10,000. So how do we classify? Mild thrombocytopenia, platelet count between 1 to 1.5 lakhs. Moderate is 50,000 to 1 lakh. Severe thrombocytopenia is less than 50,000. What are the risk factors? Gestational thrombocytopenia explains 70 to 80% of all cases of thrombocytopenia in pregnancy. Hypertensive disorders, as Dr. Pai was just talking about, account for 20%, and ITP, that is immune thrombocytopenic purpura, for 3 to 4%. Now, causes of thrombocytopenia in a pregnant woman. Pregnancy related could be gestational thrombocytopenia, preeclampsia, eclampsia, HELP syndrome, and acute fatty liver of pregnancy. Not related to pregnancy. One of the very important reasons is pseudothrombocytopenia. What is pseudothrombocytopenia? See, normally when we send the blood for testing, it is collected in EDTA vials. Now, in that, what happens? The platelets tend to clump and they stick to the walls of the tube. So, the automatic analyzer does not take those platelets into consideration, and there is a false report, that is a pseudo report of thrombocytopenia. So please, whenever you get a report of thrombocytopenia, please tell the lab to take a peripheral blood smear and do the counting manually, because initially it was thought it was the EDTA only which was responsible, and if you send the blood in citrate vials or in heparin vials, then the pseudothrombocytopenia won't be reported. But now it is said that even in those cases, there are some cases in which the platelets tend to clump and then they are not reported. So the best would be a peripheral blood smear and a manual counting. That will give us the exact idea. So first of all, it is very, very important to ascertain whether the patient actually has pseudothrombocytopenia, has got thrombocytopenia, or it is just a false report. Now, second cause could be immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, or HUS, hemolytic uremic syndrome, autoimmune disease, lupus, antiphospholipid syndrome. We have infections, HIV, HBV, HCV, sepsis, viral infections, dengue infections, then DIC, drug-related causes, not only heparin, even sulfur-containing antibiotics, and there are several other drugs which could actually cause thrombocytopenia. Von Willebrand disease, type 2B, bone marrow dysfunction, hypersplenism, nutritional deficiencies, vitamin B12, folate, and even iron deficiency anemia could be associated with thrombocytopenia. Now, first we'll discuss this common problem which is happening nowadays, that is dengue as a cause of thrombocytopenia. Dengue fever causes a decrease in the platelet counts due to several factors. The dengue virus directly affects the bone marrow, leading to a decreased production. The virus can cause increased destruction of the platelets in the bloodstream. The immune response triggered by the dengue infection can also cause thrombocytopenia. These cases of thrombocytopenia are mostly transient and resolve as the infection subsides. The platelet counts in these cases drop from lakhs to thousands from the 4th or the 5th day, and immediate treatment is needed to prevent further deterioration. Signs and symptoms would be high-grade fever, headache, rash, muscle and joint pains, nausea, vomiting. The symptoms typically last for 2 to 7 days. But in severe cases associated with thrombocytopenia, there could be serious bleeding, which can be life-threatening, because I think all of us are very well aware that a normal platelet count is needed to prevent unnecessary blood loss, as they are responsible for attaching at the site of injury and preventing bleeding. So, effect of dengue on pregnancy. It can cause miscarriage in 20% pregnancies, increased risk of preeclampsia, fetal distress, preterm delivery, stillbirth, neonatal deaths, increased risk of maternal mortality is there. And when we talk about neonatal mortality, these antibodies to the dengue virus in the infected mother can cross the placenta. The newborn can develop dengue hemorrhagic fever or hemorrhagic shock syndrome. Now, investigations. Dengue fever NS1 antigen test helps to detect dengue in 1 to 5 days. Later, we can do IgG and IgM antibody testing. Besides thrombocytopenia, there could be leukopenia also. So how will you manage these cases? For mild cases, paracetamol, we all know, helps to reduce fever and body pains, and it is safe in pregnancy. Hydration is important for maintaining embryonic fluid levels. Antibiotics may be needed if there is associated leukopenia. No aspirin or over-the-counter medicines should be taken. Preventing mosquito bites is of utmost importance because it is the Aedes mosquito which is responsible for this dengue. In severe cases, platelet transfusion may be needed. Blood platelets can improve by consuming the right type of foods. Foods such as leafy vegetables, iron-rich foods, lentils, pumpkin seeds, papaya, and not only papaya, papaya leaves extract, and dairy products, and many fruits, kiwi, pomegranate, even oranges, even coconut water is very helpful. And veggies like broccoli, cauliflower. So it's not only about kiwi and papaya leaves, it is about improving the amount of taking iron-rich foods and foods which are rich in actually B complex also and folic acid also, B12 also. So you need a comprehensive diet. Gestational thrombocytopenia. It's a benign condition with moderate thrombocytopenia. The platelet count is 1.3 to 1.5 lakhs. GT is asymptomatic. Normally, it occurs in the second half of pregnancy. There is no history of thrombocytopenia outside pregnancy, and the platelet count spontaneously returns to normal levels within the first 2 months postpartum. It is not associated with any maternal or fetal risk, and it is of utmost importance, however, to attain a platelet count before epidural anesthesia is being given. When you are suspecting gestational thrombocytopenia, but you find that the platelet level have dropped and they are to the tune of 50 to 80,000, then please consider ITP as another cause that could be responsible. Prednisolone in daily doses of 10 milligrams per day for 10 days before birth should be administered in such cases in order to increase the platelet count and avoid possible anesthetic and obstetrical risks. Now, when we come to ITP, it is a rare autoimmune disorder which is characterized by anti-platelet glycoprotein antibodies that stimulate platelet destruction in the spleen. Thrombocytopenia in ITP is generally moderate, but the platelet count is normally less than 1 lakh. Patients may be completely asymptomatic or they may present with bleeding depending on the platelet levels. So what are the lab evaluations? CBC reticulocyte count, peripheral blood film, LFT, TFT, quantitative immunoglobulin level measurement, and direct antiglobulin test, APLA, ANA, H. pylori, HIV, HCV, HBV, von Willebrand type 2B testing, dengue, malaria, serology. Gestational thrombocytopenia versus ITP. Unlike GT, ITP can occur anytime during pregnancy and normally it occurs in the first trimester. So in the first trimester, if you encounter thrombocytopenia, please keep your eyes and ear open for ITP because normally gestational thrombocytopenia comes on in the later half of pregnancy. Most pregnant women with ITP may have history of thrombocytopenia prior to pregnancy or may present with other immune-mediated diseases. Platelet count does not spontaneously improve postpartum, unlike GT. Pregnancy does not worsen the outcome of ITP, but there could be adverse fetal and maternal consequences in some cases. Spontaneous bleeding is the main maternal risk, especially when the platelet count falls less than 20,000. Steroids or IVIG are recommended before 36 weeks if the platelet count is under 30,000, patient is symptomatic, or an invasive procedure is being considered. How do we manage? Around delivery, the aim is to maintain platelet count more than 50,000, which is safe for vaginal and cesarean. But remember, for epidural, we must make it up to 75 to 80,000. IVIG at a dose of 400 milligrams per kg per day for 5 to 7 days have relatively rapid therapeutic response. Within 1 to 3 days, it comes on. Or prednisolone in a dose of 10 milligram per day can be increased even up to 30 milligrams. Therapeutic response within 2 to 14 days could be used for treatment during pregnancy. The first line therapy drug is prednisolone. It is considered safe, but can induce or exacerbate gestational diabetes, maternal hypertension, osteoporosis, weight gain, and psychosis. Prednisolone, we know, is metabolized by the placenta, but high doses have been linked to fetal adrenal suppression and a small increase in the incidence of cleft lip and palate if it is used in the first trimester. In severe cases of thrombocytopenia, unresponsive to alternative therapies, splenectomy may have to be performed in the second trimester of pregnancy. Pre-splenectomy immunizations are safe in pregnancy because all vaccines required are inactivated. 2017 UK guidelines for platelet transfusions say that the life of the platelets is only 5 to 7 days, and repeated transfusions cause production of platelet antibodies. Hence, platelets should only be used in an emergency. When emergency cesarean delivery is required and the platelet count is under 50, platelet transfusion and IVIG is recommended. ITP is itself not an indication for cesarean, and only obstetrical indications are there. IgG, anti-glycoprotein platelet antibodies, can cross the placenta and could induce neonatal thrombocytopenia. The risk is to the tune of 5 to 10%. Now, there's no correlation as such between maternal and fetal platelet levels. It's not that if you improve the maternal levels, then the neonatal levels will automatically go up. And maternal response to treatment does not protect the fetus from possible neonatal thrombocytopenia. Neonatal platelet levels should be determined at birth and daily monitored. Lowest levels are 2 to 5 days postnatally. When the platelet count in the newborn is less than 50,000, please do a cranial ultrasound because there is a risk of ICH. When the platelet count is between 30,000 to 50,000, IVIG treatment should be given. Less than 30,000, platelet transfusion along with IVIG is recommended. Now we come to thrombocytopenia associated with hypertensive disorders. Thrombocytopenia associated with hypertensive disorders like preeclampsia, eclampsia, HELP syndrome, AFLP is second leading cause of thrombocytopenia in pregnancy. Thrombocytopenia occurring is a sign of hypertensive disorder severity, and the levels rarely fall below 20,000. Preeclampsia causes 20% cases of thrombocytopenia in pregnancy. Now, talking about HELP syndrome. HELP syndrome, we all very well aware what a dreaded disease it is. It complicates 10 to 20% of all cases of severe preeclampsia. It can occur without proteinuria or hypertension, and diagnosis could be missed. 70% of cases develop before delivery, but 30% may come on postpartum. Platelet count less than 1 lakh is one of the diagnostic criteria of HELP syndrome. Acute fatty liver of pregnancy associated thrombocytopenia. AFLP is a rare but severe condition of third trimester of pregnancy. Clinical manifestations would be abdominal pain, nausea, vomiting, anorexia in conjunction with several specific lab changes such as severe hypoglycemia, hyperuricemia, elevated transaminases, renal impairment, blood pressure may be in the normal range. It may lead to the diagnosis of AFLP. Thrombocytopenia could be very severe with platelet counts going below 20,000. The only effective treatment actually of preeclampsia, eclampsia, HELP, and AFLP is delivery. Aim is to maintain the platelet count more than 50,000. Dexamethasone 10 milligrams every 12 hours, 2 to 4 dose antepartum, 2 dose postpartum is usually recommended. If there's hemolysis, thrombocytopenia, and renal dysfunction worsen, plasmapheresis could be used. In absence of other complications, platelet count usually returns to normal values by 4th day postpartum and reaches 1 lakh by day 6. Thrombotic thrombocytopenic purpura. TTP is defined by a pentad of microangiopathic hemolytic anemia, thrombocytopenia, fever, neurological manifestations, and renal impairment. Creatinine levels in TTP are not increased and median platelet count is 10 to 30,000. It can, however, present without the full pentad. Types of TTP could be familial, characterized by constitutional deficiency of ADAMTS13, non-familial by production of anti-ADAMTS13 antibodies. So deficiency in ADAMTS13 activity is also there in DIC, HUS, preeclampsia, and HELP. It's normally less than 40%, but severe deficiency, less than 5%, is specific for TTP. And the blood must be taken prior to the treatment to assess the baseline ADAMTS13 activity. So how do we manage? The stillbirth rate in pregnancy-associated TTP is 40%. So actually, we have to be very careful, monitor very carefully, and sometimes we may have to deliver the baby prematurely also. So the fetal prognosis will depend directly on the gestational age at birth. Hemolytic uremic syndrome. It has a common mechanism with TTP. Distinctive feature is more severe renal impairment. Types could be typical form caused by E. coli, atypical form, which is associated with pregnancy and related to congenital defect of alternative pathway of complement system, and occurs in most cases postpartum. So how do we manage this? Every pregnant woman with thrombocytopenia and microangiopathic hemolytic anemia should be suspicious for TTP or HUS. Lab investigations are done, and increased creatinine as a marker of renal injury goes in favor of HUS. But unlike preeclampsia and HELP syndrome, delivery does not influence the outcome of the disease. First line treatment in these cases is plasmapheresis and administering FFP as soon as possible. Plasmapheresis is repeated until normal level of platelets and LDH are reached. For renal impairment, temporary dialysis could be required. For atypical HUS, eculizumab appears a promising agent. Eculizumab is proven efficient even in paroxysmal nocturnal hemoglobinuria during pregnancy, and the treatment is considered safe. Recurrence rate, risk of recurrence in subsequent pregnancies with acquired TTP is only 20%, but with congenital TTP, it is 100%. Von Willebrand type 2B. It's a rare cause of thrombocytopenia in pregnancy. There is a qualitative defect of von Willebrand factor. Women with this condition may present with thrombocytopenia for the first time in pregnancy, and the platelets can drop to values less than 20 to 30,000. Levels of von Willebrand factor and factor 8 should be increased to more than 50 IU per deciliter to cover any surgical procedures. Platelet transfusions may be required together with factor 8 replacement if the platelet count is less than 20,000 antenatally, prior to any invasive procedure, if bleeding occurs, or if platelet count is less than 50,000 around delivery. DIC, we all know, is another cause of thrombocytopenia. So take-home messages. Thrombocytopenia in pregnancy is a benign condition mostly, but in some patients, it may be associated with more severe etiologies. A thorough history, complete physical examination is the initial step in the evaluation of thrombocytopenia in pregnancy. A review of the peripheral smear is the first step in the lab evaluation. I have said initially, we have to rule out pseudo thrombocytopenia and schistocytes. So peripheral smear is very important. Gestational thrombocytopenia is a diagnosis of exclusion, does not require any intervention as it resolves spontaneously. ITP is the most frequent cause of thrombocytopenia in the first trimester, but it is a diagnosis of exclusion. Corticosteroids and IVIG are the first line treatment for ITP in pregnancy. Rituximab is safe in pregnancy for treatment of ITP, but it may cause transient beta cell lymphopenia in the neonate. However, it resolves spontaneously. TMA, thrombotic microangiopathy, is managed by delivery of the fetus. Thrombocytopenia and other abnormalities may take longer to recover. TTP is rare during pregnancy. Up to 25% of TTP in pregnancy are due to congenital lack of ADAMTS13. Eculizumab, though it is category C, but several reports show that it is safe for the management of atypical HUS and paroxysmal nocturnal hemoglobinuria in pregnancy. So just small important points to remember. Mode of delivery depends on the obstetrical indication and not on the platelet count. Platelet counts more than 50,000 is safe, but for epidural, 80,000. In patients with gestational thrombocytopenia, if the platelet count falls below 70,000, please consider ITP. Platelet transfusions are not required for low platelet counts unless the patient is bleeding or you have to do an emergency procedure. Neonatal outcome is excellent in neonates born to mothers with gestational thrombocytopenia. Transient thrombocytopenia can present in neonates born to mothers with ITP. In less than 1% of neonates, it may lead to ICH. And a request to everyone that I am seeking support for Foxy President as I stand for this important and prestigious post in 2024. Thank you all so much for your patient hearing.
Thank you very much, madam.
Thank you. Yeah.
Nice talk. I request Dr. Murlidhar sir to sum up and give his remarks about the talk.
Yeah, madam, as usual, it was excellent talk. You gave a very comprehensive view about the thrombocytopenia and pregnancy, including the gestational thrombocytopenia, which is the mildest form, transient, fortunately, but all others are definitely, we have to look for it and detect it and treat it. And they have given the newer drugs that are in the market, their side effects, their advantages and disadvantages. Also, you spoke about how to conduct deliveries in cases of thrombocytopenia, saying that the mode of delivery does not depend upon it, but it depends upon the other factors. But having taken the decision, what should be the level of platelets in each of the situations? So it was very comprehensive, very useful to postgraduates, practicing clinicians, and everybody. Thank you so much for that. Now I would request Madam Tobi to give her remarks.
Vidya ma'am.
Rajeshri, I'm driving my vehicle.
Okay.
So, but I just listened to Ranjana and I think it was a very comprehensive talk. And I must congratulate her to compile this thrombocytopenia. Always we are in dilemma, and there are diagnostic dilemmas also. Yeah. So and treatment dilemmas also. We are very fearful when the platelet count drops, and most commonly we manage them. The mostly we are fearful about how to manage the complications of these, and many times these component therapies are not available at every time, and we tend to refer the cases. But really we have to differentiate between this gestational thrombocytopenia, and most common cause we get is preeclampsia. So if we do the series and the help syndromes, we have to manage at tertiary care level, and the anesthetic is mostly they refuse. They don't have a proper idea at what means platelet count we should give it, and many times we have to teach them this is not the case, and we have to definitely don't we are the people who will be managing post operatively. They are worried about various complications during anesthesia. So as I'm driving, I am not very much, I could not concentrate much uh, on the talk, but the I concluding slides I could listen, Ranjana. I will definitely go through your talk uh, as it will be uploaded in our Kcog website. So all the best for your Foxy presidential candidature.
Thank you. Thank you so much.
We wish all the best.
Thank you.
And definitely, I'll be missing your conference, but sometimes definitely I will come and meet you. And we will be meeting often. Thank you very much.
Thank you very much, Vidya ma'am. Please drive back safely. You're very precious for us.
Yes.
Sir, any questions or any thing?
So I don't think there are any questions in the chat box.
Yes, sir.
I would like to ask one question, madam. What is your experience on using factor 7 and other factors? Did you have to use them?
No, I have never had to use them.
Because we had a very bad case of the severe thrombocytopenia, and that was actually a complication of DIC.
Oh.
And yeah, we had to get it from Vellore, and we could save the patient because it's very expensive.
But, yeah, it is very expensive.
So we could save the patient. So that is one of the options that we have finally. And as you correctly said, platelet transfusion is definitely useful as you are planning to conduct the delivery. If you give it because it will be destroyed immediately, there's no point in giving earlier unless it is so severe so that there is a fear of spontaneous bleeding. Yeah. Otherwise, usually reserve it at the time of procedure or at the time of delivery. And you really highlighted that if the patient is on any blood thinners, what in the layman term they call, it should be stopped. Like even for tooth extraction, they request us to stop 1 week before. Here again, we have to highlight that point.
But in oxaparin, we give right till the end in our patients.
Yes, that can be stopped just 6 to 12 hours earlier.
Yeah.
But to be restarted soon after the cesarean or whatever delivery, after the 12 hours.
Actually, my daughter-in-law, she had severe preeclampsia in the first child, and the child, she was in NICU. She had to be taken out prematurely. I only did the cesarean, and then she developed severe thrombocytopenia. It went below 30,000. So platelet transfusion, IVIG, everything was given to her.
Yeah.
So
yeah, in cases of especially the thrombocytopenia due to preeclampsia, post delivery, also there is a small role for 2 doses of steroids.
Yeah.
Which instead of giving platelet all the time, especially or if platelet is not available, most of
my grandchild they gave 2 IVIGs.
Correct. Okay, that is of course again very expensive. Not everybody.
Yeah.
Can. Yeah. What is your opinion on single donor platelet and pooled platelet, ma'am? Is there any difference?
See, normally, we use only single donor platelets.
Yeah.
I don't have any idea about pooled.
Yeah. Okay. Yeah. Single donor is always better. That's what they is advise.
We are always using single donor, especially during COVID. So many times we had to, it was prescribed and we had to use. On my own sister-in-law, it was given.
I'm very happy that we discussed today a sort of rare topic, which is not in the sense, not usually discussed in conferences and CMEs. Yes. Nobody wants to touch this, but it is so important. And especially, in obstetrics, bleeding is the one most dreaded complication. And if it is due to thrombocytopenia, all the more it is challenging. And you have solved all that so nicely for us. Thank you so much. And I
Thank
also
you
would
so
like to
much.
wish you all the best, most deserving person to lead Foxy.
Thank you so much. Thank you so much, Dr. Pai.
All the best to you.
Thank you so much, sir, for compiling and putting the key points in Toto and bringing out the very practical, relevant points as to how the platelets have to be administered. Madam, I thank you very much for sparing your time and gracing the occasion and addressing all of us on a very relevant and important practical point of thrombocytopenia. And along with Murlidhar sir and Vidya Tobi ma'am, we from Kcog and Kcog wishing you all the very best for your great tenure ahead. Wishing you all the best, ma'am.
Thank you so much. Thank you so much.
Suman Gaddi, ma'am, to please deliver the vote of thanks. Sir, can we go for the vote of thanks?
Yes, please.
Yeah,
And thank you, Dr. Pai and Dr. Vidya and Dr. Rajshri for giving me this opportunity.
Thank you.
Yeah, good evening, all. First of all, I would like to thank the entire Kcog and Kcog team for arranging such wonderful webinars. I thank Dr. Murlidhar Pai, Chairman of Kcog and today's convener. And I thank Dr. Vidya Tobe and Dr. Rashi Paledi for their inputs regarding this topic. And today's speaker, wonderful talk on thrombocytopenia in pregnancy by Dr. Ranjana. It was really wonderful, the very much needed topic in day-to-day practice. It was so clear, comprehensive. And I then thank all delegates who have logged in. And I also thank Mr. Arun who has arranged for this Zoom platform. Thank you, one and all. Good night.
Thank you. Good night.
Thank
Happy
you.
Diwali to everybody.